Natalie Nidham, your host. Welcome back. Most cardiologists don't talk about joy, purpose, or the heart having its own kind of intelligence. But today's guest does. I'm joined by Dr. Regina Druz, a cardiologist who went from elite academic medicine to completely rethinking how we approach heart health. We talk about the moment traditional cardiology stopped answering the questions she was seeing in real patients, why prevention and personalization matter more than ever, and how vascular aging quietly shapes everything we call longevity. This conversation is thoughtful, empowering, and refreshingly human. Now, this episode is brought to you by Cozy Earth, by Magnesium Breakthrough by Bioptimizers, and by Level Up's Liver Complex, all with special offers just for you. See the show notes below for details, and enjoy the show. Dr. Regina Druz, welcome to the show. It is an absolute pleasure to have you here and very much looking forward to this conversation.
Natalie, thank you so much for having me.
Well, we met at a conference in New York, the Her Longevity Conference in the fall. But before that, I'd heard of you through one of the women who attends my longevity retreats in Sedona because you work with her, you treat her husband as a patient.
Oh, wow.
Yeah. And she had said to me, oh yeah, my husband's cardiologist. She's all over the stuff. You absolutely must meet her. And I was like, yeah. You know, everybody's always telling you that. And then when we met and I heard you speak at the conference, I was like, yeah, okay, she's right. We need to talk. And I think part of it for me also is we don't often get a female perspective in the cardiology world. Mm-hmm. I'm all about gender equality and whatnot. I think men have obviously have so much to offer. But I think that when we have a lack of female voice in this space like this, it does women in a disservice. Would you agree? Look, a doctor is a doctor, and a good doctor is a good doctor. But what are your thoughts on that, on bringing a female perspective to different topics like this one?
Natalie, I think you're spot on because in cardiology, we sort of recognized quite a few years ago that women as patients, for example, were underrepresented in a lot of cardiovascular trials. So there has been an expanded focus on trying to figure out what might be different for patients who are women versus patients who are men. And sort of the, side effect of that, I don't know if we can call it a side effect, but related to that was a recognition that women as physicians are still not don't have parity in cardiology, right? We still are the minority. And so American College of Cardiology, American Heart Association have been very active in promoting women cardiologists, creating opportunity for women in cardiology so that we could bring our perspectives and our life experiences to cardiovascular disease. And boy, oh boy, there are a lot of these experiences that we can bring for sure.
No kidding. Well, aren't women more likely to be underdiagnosed or misdiagnosed when it comes to cardiovascular, or at least they were. I don't know if that's changed much, but I know that in the past, a woman presents at the hospital with cardiovascular symptoms or stroke symptoms and very often would be sent home. Like they just were missed.
That's actually true, although I think the pattern is changing. A lot of work has been done to educate practitioners, to create initiatives. But a lot of academic institutions, for example, now have women-specific cardiovascular centers, right? Or women health centers.
So it has changed.
It has changed to a degree. But, I can tell you that at least on the institutional, organizational level, the cardiovascular health, it's still not integrated the same way, for example, as breast cancer screening, right? So if you go to an institution, a health hospital organization, and you look up online and you see they offer women's health, right? There's a women's health center. The procedures offered there, for the most part, are diagnostics for breast cancer prevention, which of course is very important. But the fact remains that cardiovascular disease kills 10 times as many women as breast cancer. And so where's that level of screening, right? So I think we did a good job educating practitioners, physicians, and even some women, not all women, that symptoms that women experience may be atypical. That's what you're referring to. And they should be taken seriously, right? But we haven't really extended that into like what happens before the symptoms, right?
Well,
you know,
and we're going to get into that because menopause plays a big role in that evolution of how things change. But before we do that, I'm jumping ahead of myself, which I sometimes do. I want to go back to the beginning of Regina. And when, if we go back even to your childhood, like when is it, even in your childhood, what can you think of the first moments where you became aware of the heart, whether it's emotionally or physically, like even before you knew you'd become a cardiologist? Like, was there something in your childhood that if somebody had been looking back then saying, look at the direction you were going in even then?
There probably was an overall trajectory, not necessarily a childhood defining moment, more like young adult defining moment, which was a little funny. But, my parents are not physicians. We come from what used to be a former Soviet Union Republic of Ukraine, now an independent country of Ukraine. And my aunt and my cousin were physicians, but they were OBGYNs. And so, in my family, it was always thought that, if I'll become a doctor, I'll be an OBGYN. And so when I told them I am becoming a doctor, but I likely will be a cardiologist, they were absolutely shocked. They were horrified. They're like, cardiology for a woman? Are you insane? And I'm like, no, I'm not insane because there is a need for it. And that's what I like. And, and I think I honestly realized I'll be a cardiologist in my first semester of medical school. We had a lecture on pathophysiology, basically, how things work and how things break when they're diseased. And a lecturer was giving us information on cardiac cycles, sort of relating the electrocardiogram to all the sounds and all the little pressure tracings. And I was so intrigued by this because the beauty of it, the elegance, how it's perfectly positioned to respond in health and disease states. And we take it, we don't think about it. It happens on autopilot. And yet this is such a system. And, I think later in life, as I transitioned more into integrative or personalized medicine, the heart connection, not just physiologic, but emotional connection, right? Spiritual connection. Our heart has its own brain, right? And its own spirituality wiring. So heart had been at the heart of me and always intrigued by this and still having fun after nearly 25 years as a cardiologist.
I love it. The fact that you get such joy out of your profession is we don't hear that often. People are motivated, they're inspired, but joy is not something that comes up very often. And that comes through when you speak. I have to say that when I heard you speak at Her Longevity, when we met, when we had dinner, I was like, wow, you bring a different energy to the space than we normally associate with doctors, which I think it's part of your passion for what you do, which really comes through. So, if I'd met you as a young doctor at Cornell and New York Presbyterian, where you got your beginning, what was the standard cardiology playbook you trusted most at that time, and where has it changed for you?
So great question. So back then, right, we're going like, in medicine we say age of the dinosaurs, but maybe it wasn't that, that long ago. I finished my fellowship in 2001 and New York Presbyterian Cornell was an amazing place. I have nothing but great memories. Most of my attending physicians were men. right? As is predicted. If there were women cardiologists, they were sort of hidden, they were kind of like in the areas of cardiology, which are sort of like bread and butter areas, but not necessarily, the sexiest, top of the line. They were not placing the newest stents or wiring the latest pacemakers. They were more like, doing clinical work or cardiac imaging, which was my area where I went into. And so what I remember is really, those large portraits of esteemed physicians that were lining the halls of, back then it was Cornell University, became Weill Cornell School of Medicine, all of them male, and sort of trying to look up to them and trying to think like them and trying to emulate, this pattern of very traditional cardiology, right? And that traditional cardiology had accomplished extraordinary advances. It had saved countless lives. But pretty soon, within 5 to 10 years of this, I began to realize that it also missed and continues to miss in many ways an opportunity that all of us as humans want, which is that opportunity for prevention and personalization. And so I realized, 10 to 15 years down the road, which is sort of like that interesting space as a professional, you are good enough, you're experienced enough in what you need to do, and you do it really well. Yeah. And that when you're finally on top of that mountain, all of a sudden you start seeing that there are some other peaks that you have not even known existed before, right? There's other peaks that are yet to climb. And, and once you see those peaks, you can't unsee them. And so, I had a little bit of, not a crisis, but I had a realization that something is missing. And I realized over time that we made such tremendous strides in disease management, and we continue to make those strides, but we have done next to nothing in health optimization. And so I think now in heading, into greener pastures and taller peaks, especially with artificial intelligence and sort of N of one approach, this is where that opportunity finally presents itself, not as an academic pursuit, but as something that each individual can do for themselves, that then they can create that change that they need in order to optimize their health.
Hey folks, I just wanted to throw a little message in here for those of you who are sending me all these incredible questions on social media or through YouTube or even on Spotify, wherever you're listening to the podcast. I wish I could get back to you, each one of you personally, but unfortunately I can't. And because I cannot, I created, about a couple of years ago now, I created a membership community where I get to hang out with people just like you. I do live weekly Q&As, almost weekly anyway. We also do have podcast guests come in to answer everybody's questions and do presentations. You get to interact live with those podcast guests. We will sometimes do challenges with some of the partners. Like in 2026, we have a mitochondrial enhancement challenge coming up where we're going to be testing mitochondrial function. We're going to be testing people's deuterium levels. If you haven't heard about deuterium, we've got podcasts coming down the pipes on that. And then people will be invited to follow a personalized protocol and then retest their mitochondria on the other side. We offer that in the membership community, and we do it at incredible discounts that you just can't find anywhere else. So if you're interested in hanging out with me and other like-minded people, which actually happen to include some pretty awesome practitioners and even some previous podcast guests who've come and joined the community, then I invite you to check it out on my website, natnidham.com/the-longevity-community, or just go to natnidham.com and look for the longevity community tab at the top of the page. Click on that and see if this is right for you. I would love to see you there. And we could make 2026 our best year ever together. So once again, that's natnidham.com. Just look for the longevity community tab at the top of the page. Now let's get back to the show. So was there a particular patient or event that kind of in your career that secretly kind of haunted you, or what provided that crack in your faith that
allowed you to see those peaks. You know what I mean? Sometimes there's something happens and you're like,
Yes.
there's got to be a better way.
Yes. So I had a patient and I had a drug rep. A patient who I get, actually, they were a couple, and I write about them in my upcoming book. So they were an older couple. They were not necessarily a couple of means, sort of, in their 60s and 70s. Each of them had some chronic conditions. And so they would come to us for cardiology evaluation. And usually that would involve what we typically do with patients, getting some imaging studies, physical exam, doing something called a stress test. And at the time, I was directing this whole section in a hospital where I worked, this stress testing section. And it was amazing to me that those individuals, even though they were older, they were in their 70s, they actually did very well, better than better than expected based on their age and gender, right? Because we always look, what should people actually do? It depends on person's age. It depends on cardiovascular fitness. So there are some norms in traditional cardiology. And so they did much better than that. And it intrigued me because the pattern that I was seeing was actually the opposite. I was seeing younger patients doing worse than expected. Here were older patients doing better than expected. So I started asking them, and I learned that, they were following, some specific nutritional advice, nothing too crazy, just, eating more vegetables, eating more fruits, daily walking. They were gardening, they were in relationship, they were together. And I thought to myself, it's interesting because these are not the type of things that most people shouldn't be able to do, but yet it's having such a profound impact. And at the same time, as I said, drug reps were the norm in health institutions. I think right now it's a little bit more regulated, but, back then it was, they would come, they would, present new medications, they would bring lunch to the whatever departments they were lecturing in or sponsor a conference. And so I met a drug rep who was just like me from the former Soviet Union. She was of the same age. Actually, our birthdays were exactly the same. And so she was like my sister from another mother that just surfaced. And she was representing a company that had one of the major cardiovascular drugs. But on her own, she was a supplement queen. So she would always bring me some sort of, first it was essential oils, then it was some sort of other supplements. And and her name was Alona. And I said, we can't really have this here. This is like a house, this is a hospital. This is not a supplement store. And I blew her off, for a little bit. And then, but I kept on thinking about this couple, and they sort of were percolating through my mind. And I listened to something, I think, online. It was Dr. Mark Houston. And so Dr. Mark Houston at the time, he was doing a lot of work for A4M. He was giving presentations, he was giving modules. And I looked through the whole roster of presentations, and the only available module was the last one, the closing sequence. So I went to, there was no virtual education back then. So I went in and, I signed up for that last sequence. And so we were in the room with people, and he approached me during the break and he says, "Who are you?" He says, "I have not seen you in my other modules. You know a lot of the answers to my questions. And I know you didn't take my other modules." And I said, "Well, I'm a cardiologist and so and so." And he listened and he nodded his head, and, he's from Tennessee, so I won't be able to imitate the Southern drawl, but he said something. And, this is what he said. "Regina," he said, "once you drink an integrative medicine Kool-Aid, you will never look back." Now, this was Saturday, and I thought to myself, what does he know? I'm a board-certified cardiologist with multiple boards in a large academic institution. This academic, this integrative medicine Kool-Aid, and my, friend Alona with her supplements and essential oils. That's just not what's going to float my boat. And so I flew back home. Monday was my first clinic day. And that first clinic day on Monday, as if he were in a room with me, because every patient, what we discussed that weekend, that integrative medicine Kool-Aid would just appear out of nowhere. And once I started, and my knowledge base was minuscule, but once in that regard, and once I started even mentioning this, I had a clinic which was full, and it was, it was like being in, in the Soviet film and being a spy, because patients would come in and they would whisper, they're like, "We hear you're a doctor who advises on supplements." I'm like, "Oh my God, just don't tell my chief, because this is going to get me in huge trouble." So that was the beginning of what became, I think, my purpose and my journey. And coming back to your comment and passion, and I thank you for recognizing that. This is why I'm passionate about it, because there is freedom in it and creativity, and there's an opportunity to change people's lives. And I fully embrace it, even though I know that we are far from knowing everything. But guess what? The same is true for traditional medicine as well. So, I think we are more convergent now in this approach than we had ever been before.
Yeah, no, I think it is amazing how, and this is going to sound a little woo, but it is amazing how the universe moves sometimes. Mm-hmm. It's almost like, you'd seen the peaks and you weren't exactly sure what to do with them.
Right.
And then you go to this one talk with this one physician, and it just cracks the door open, and it changed the trajectory of the way you practice medicine forever. You never went back.
Really? I never went back. And, I never went back, because that vision that transpired in that room over the weekend, and the concepts that he took all the concepts that, of course, we knew about those concepts as cardiologists or primary care physicians, but he brought it to a clinical level, to a patient level, didn't really exist in a traditional cardiology practice. And unfortunately, it doesn't exist even till this day. I just read an article, and I'm writing a blog post on it on Substack about a discussion. There's a great debate amongst cardiologists that was published in European, I think, Heart Journal, on the approach to lipid management. And so I learned a new term. Yes, I learned a new term. It's called fire and forget. So I'm writing an article about fire and forget rebellion, because fire and forget is a strategy where a patient comes to a physician, they have elevated lipids, high cholesterol, and they're given a prescription and told to show up whenever for the blood work, right? And that's fire and forget, right? There is nothing really personal about this. It's sort of like putting people in a box. And so, you see, and so the debate in the article is about fire and forget and personalized strategy. And just the very fact that we even having this debate in a mainstream cardiology journal, because European Heart Journal is a very large cardiovascular journal that, people read all over Europe. European Society of Cardiology is one of their main journals, written by people that are knowledgeable in lipidology. And, I'm seeing people who are quitting their doctors over this fire and forget strategy. Fire and forget.
Sorry, fire and forget means they're given something and then sent on their way. Nobody follows up. Nobody checks to see if it's working, really.
Well, they might check to see if it's working and then give another prescription. So in other words, what the patients want to know is the why. What the doctors are giving them is the what. Right. Yeah. So that's where the disconnect is. That's why, what we do, our model at the Holistic Heart Centers is the opposite of that. Right. We look at the why first so that we know what to do. Right. The traditional cardiology is the reverse. This is what it is, and this is why we're giving you something.
So you basically got to a point in going from a national expert in cardiac imaging and a hospital-based cardiologist, you basically got to the point where you couldn't practice the cardiology you wanted to practice anymore. And that's why you started the Holistic Heart Centers.
Right. And so, the mental disconnect was there, and also the cardiology at the time, sort of in mid-career, this was a challenging time for cardiology because reimbursements were falling. There were a lot of consolidation of cardiology practices. All of a sudden, this distinction between, private practice community cardiologist and academic cardiologist was blurred, and reversed, because it used to be that academic cardiologists, they would be, just as I was, speakers at national conference, experts. They would write articles and highly regarded. And of course, the community cardiologists were highly regarded too, but they were known as the worker bees. And virtually overnight, the hospitals and healthcare system said, you know what, those worker bees bring in good revenue. Let's shift the paradigm. And the entire paradigm shifted. And I think it continued to shift even after that. But at that point, my mind was made up. And, some of my colleagues said, what are you doing? You're committing career suicide. And I didn't have an answer at the time. And a big part of me thought that perhaps they're right, because, opening private practice in a location that is so saturated with cardiologists that you could literally, have the same test 10 times in a span of 1 mile if you just wanted to have it done, but the vision was there. And so I'm happy that it worked out. I don't think it's just luck. I think, luck, that famous, no luck there. There is this famous saying, but Louis Pasteur, right? Chance favors a prepared mind. So, so that was a situation, I think, of a prepared mind.
100%. So you went on to create Fit in Your Genes as a precision cardiology program. What problem does this program try to solve that standard cardiology just doesn't even see, doesn't even acknowledge it, really?
Right. That's a great question. Thank you for asking. And going back to that, fire and forget versus personalized approach, that's exactly the gap that the program is poised to solve, right? So instead of trying to fit a patient to some sort of a framework system that puts them in a box, Fit in Your Genes personalizes patients' assessment of cardiovascular risk and gives them a pathway toward health optimization so that we can pick the right strategy that is going to lower their risk and, of course, optimize their health and longevity. So this is a 180-degree reverse of how traditional cardiology is practiced, certainly from the preventative strategy. Can't, and it's interesting because it also may work, of course, and it's beginning to, even in cases where the management is really disease management. Like, for example, picking the right medications after a person had a heart attack. We're beginning to bring some of the philosophy of this strategy into even into that domain. But, it's primarily focused on prevention and personalization. And what that means practically is that if a patient has elevated lipids, they don't get an automated, statin plus, Zetia plus PCSK9 inhibitor, which is what cardiologists are doing now. And each of those medications has their role. They're very important medications. And for each person, there might be a specific need for a specific medication. But we don't start there. We start with figuring out what is going on with this person genetically? What is going on with this person with regard to their metabolism? How are they measuring up with regard to their hormones? What's their stress is like? What their sleep is like? What their microbiome is like? And can we create a personalized map that gives us guidance? Because the goals are still the same. We want a healthy vascular endothelium. We don't want them to have cardiac events or ischemic events. We want good blood pressure. We want optimal lipid profiles. We want lowering of inflammation. So our goals between traditional and integrative cardiology we're aligned. We're not going to argue over our goals. It's just how you get there. And these are very different strategies.
It brings meaning to the word holistic and integrative, because I think one of the big shortcomings, if you will, of any conventional specialty and in the allopathic model is that they have a tendency to act as silos. And the body doesn't work. No system in the body works as a silo. And what you're saying here is we can't treat lipids. We can't treat a cardiovascular condition if we don't understand what the contributions are that are being made by every other system in the body. Like this, it just sounds so logical. It's almost it's almost hard to imagine how it doesn't make as much sense to anyone. And maybe the problem, or maybe the issue is, it starts in the beginning in med schools, where the way that med schools were designed, the education was designed, was to help to create real, true specialists in each one of these disciplines. And it's almost like it ends too soon, because the next stage should have been maybe, and here, now we're going to bring everybody together and let's talk about what feeds in to each one of these models. Like it makes so much sense. It's so incredible that people like you are doing the work, but it's so sad that it's still such a small part of how this medicine's being practiced. And I guess change takes time, but
you know what? Change takes time, but creating change is actually quite quick. And so I think we are now at an inflection point, and a big reason why we are at the inflection point is sort of convergence of, direct to consumer service offerings, whether it's blood tests or genetic tests, emergence of digital tools. You and I are wearing at least one or two of them at any given time, right? And democratizing access to medical knowledge, whether you agree with it or not. But, generative AI, all these chatbots that are popping up on our screens basically 24/7. I don't think I have met a patient recently who have not uploaded their laboratory data into ChatGPT, and so this is an example of that democratizing access and providing an opportunity for patients and for practitioners to shift their focus. So I think, the next decade, most likely, at least in my mind, will become less sort of professional physician centric and much more individual and patient centric, because with technology enablement and the demand, that's the shift that's already happening. And I think that will redefine our training models, right? It will take us out of that, well, this is what the population-based metrics are, which is how cardiology still practices. These are what, large randomized clinical trials show us. Again, it's, populations of these patients versus those patients. It is, the pendulum is already shifting to trying to personalize risk and personalize the intervention. And we're going to get there faster than most people realize.
Yeah. Well, I mean, the rate of change, it was fast before. It is becoming, it's becoming blinding at this point. And, being a physician, kind of stepping into this now, you're positioning yourself and your colleagues who are with you to meet patients where they are. Right. And to walk with them on this journey. And I think what's happening, the other shift that's happening, is that the patient that's stepping into this role now is taking agency over their care, and they're looking for a partner. They're not looking for someone who's going to dictate, this is what you do, and don't ask me any questions, which is exactly what you said earlier. So let's try to bring this into a more concrete space for the audience. Can you walk us through a concrete example of when a patient whose labs technically looked fine, that 4-letter F word, in a conventional office, but whose genomics, advanced lipids, or inflammatory markers told you that there's something completely different undergoing and about their cardiovascular age?
So great question. And I think there are countless patients like these, but I can tell you that we see patients like this every single day. So I can give you, for example, one of the most recent patients, and it's not unique to men. It could be women as well. But for men, very often, they tend to be athletic and doing a lot of things that they perceive as very beneficial to their vascular health, right? And so they, various exercise routines and various fasting routines. And, we routinely get patients who, if you just look at them sort of physically, in terms of physical appearance, they appear to be in phenomenal shape, and their blood pressure is excellent, and they don't smoke. So in other words, they don't have any of the standard traditional cardiovascular risk factors. And then, of course, we go ahead and we measure their vascular age. And there are a couple of ways we can do this. One of the well-known ways is to essentially get something called coronary artery calcium score, or CAC. And, it's easily accessible technology. It's not tremendously expensive. There are some places that actually give it for free, because that's the way that, practices or groups build up new patient referral bases. But it's no more than, a few $100s that you spend.
It's completely
accessible. And you don't need to even do it every year. It's, so the point is that I used to get, as a traditional cardiologist, before I sort of developed the integrative mindset, the holistic mindset, I used to get very surprised when patients like these, who are so invested and committed to their effort and who have perfect lipid profiles and perfect inflammation markers, maybe a few things here and there stand out, I was surprised to find extensive coronary artery disease. But I'm not surprised anymore, because we know now that whatever we do lab-wise, for example, certainly the very basic standard panels, they don't really give us the full picture, right? We're not asking what is the level of inflammation in the blood vessels? What is the metabolic profile of this individual? Do they have enough of nitric oxide to protect their coronaries? Are they oxidizing a little bit too fast, right? Is there high oxidative stress going on? Is their immune system not quite doing what it meant to be doing? Are their hormones off balance? Are they drinking themselves into something? Are they not sleeping themselves into something? So, and that actually opens the opportunity for change, right?
Right. Yeah. Well, it's interesting because just this summer in my friend community, there's a guy who was an avid cyclist, very fit, I think 60 years old, exactly the person you're talking about, dropped dead of a heart attack.
Right. Which is terrible.
Of a massive, and everybody walks around saying he was so healthy. Right. And I'm sitting there going, but he wasn't. He looked healthy.
Right.
He was walking the part and talking the talk and probably doing everything he could that he knew to do. But there was something underlying. There was some other drive. So let me ask you this. In genetics, what are some of the things that you look for that give you an indication that a patient might, things might start to go sideways when people think they're doing the right thing? I have two questions. I have that one.
Okay.
And then the other one, which is start with that one. And then the other one is a little more loaded. So let's start on the genetic front, because I think that there's things like the way that people handle saturated fat. And then there's a narrative out there, everybody needs to eat saturated fat. Like, what are you seeing in these disconnects that people are trying to do their best? They're doing the best they can, and yet they're so unaware of their own personal settings that's changing the outcome.
So I think, Natalie, what you were saying about these personal settings, let's start sort of backwards, right?
Yeah.
Because one of the things that I want to make sure that listeners are really understand is that people tend to simplify cardiovascular health or vascular health in general, right? They tend to think of it in a very linear fashion. And linear fashion being, if I exercise more, if I restrict my carbohydrates more, if I lose more weight, I am going to be essentially, age-proof. Nothing's going to touch me, right?
Yeah.
And so, but we know from clinical studies, and this is where the major disconnect is that, first of all, there is no such thing as you will have a zero risk, right? Being alive means that the risk is never zero, right? So, so that's, the risk is only zero when you're dead. But, when you're alive, the risk is never zero. So let's start there. Our derivatives of risk, what we think are the components of risk, is not personalized. It's population-based. And a person may or may not be representative of their population, because the population-based characteristics, like that 60-year-old man, he may have been told by his physicians that the typical population metrics are good right? Lipids may have been good, inflammation may have been good, blood pressure may have been good, but nobody had taken the next step to personalize it. And, cardiovascular disease, atherosclerosis, the process of aging of the arteries, which is, you heard me speak, and, I always say this, is that aging is cardiovascular. This is, a lot of people are running around and they're saying, well, it's all about muscle. It's all about protein. Muscle is the currency of aging. And I always tell them muscle is the currency of aging, but it's your vascular system that sets the interest rates. Because if the vascular system interest rate is too high, muscle. Cannot. Yeah. You won't be able to build muscle. You won't be able to maintain it. So I think, and that brings us to, so what is that, what is that thing that allows us, as you mentioned, to personalize the health trajectory of an individual? And genetics is the blueprint. Genomics is the interaction of environmental inputs with the genetic blueprint. And that's the area where interventions could actually change a person's trajectory. So, these statements that, saturated fat is bad, saturated fat is good. I just saw an article in passing that major study came out looking at incidence of dementia, and they found that people who ate more saturated fat had less dementia. But again, they excluded some of the high-risk genetic variants. So I think as we go into the future, we're going to become more precise and more personalized beyond these superficial, because right now, these metrics, as important as they are, lipids, blood pressure, sugar control, obesity, smoking, sedentary, these are really impactful metrics, but they're population level metrics. They're first base, so to speak.
Not about you. This
not
is
about you.
It's not about you. Correct. So tell us a little bit about what are the genetic lines people need to look at that's going to really help them to take it out of that population, because there's still a population for you. It's just not the general population.
Correct.
There's going to be a population of people who, for me, in my genetics, saturated fat will drive inflammation.
Exactly.
So I have people in that population that relate to me. We're just not part of the whole population.
Correct. Your parts. So this is interesting, because this is actually, this line of thought, believe it or not, comes from mainstream traditional cardiology literature. And when I spoke in London in June at the Integrative Health Symposium, I showed the papers and I showed, the article and the definitions. And this is called deep phenotyping. Right? Yeah. So we are moving away, or at least we're trying to move away from these superficial phenotypes. Is a person overweight? Is the person hypertensive? Do they eat too much salt? Do they eat too much fat? Yeah. It's sort of like these dichotomies, right? Very superficial phenotypes to deep phenotyping. And for example, the way that we do it, if we stick with the lipids, because that's what most people could, identify with, or let's say high blood pressure, is that there are numerous lipid pathways. At least 6 to 7 lipid pathways are interacting in your body at any given time. And so, when people say, oh, just take a statin, or just take Repatha, or just drop your saturated fat, they're basically, looking for the lowest common denominator that potentially could control the situation. They're not looking at this entirety of all these of this lipid universe, or what I call a lipidome. So so genetic pathways. We want to know: do you have genetic pathways that predispose you to making more atherogenic cholesterols? Right? Do you have genetic pathways that make you more likely to also have insulin resistance? Do you have genetic pathways? Doesn't mean you're going to have it, but that's the genetic machinery, which is what you mentioned, right? Do you have genetic pathways that make you more pro-inflammatory, give you some immune predispositions, potentially make you less efficient at clearing cholesterol from the circulation, right? So this is actually redefining the paradigm. There was an article in The Economist recently, and I was chuckling because I never expected this in The Economist. The article was about how there is no more good or bad cholesterol. Right?
Thank God.
And I'm I'm like,
oh my God, hallelujah.
I've only been saying this for almost 10 years, but at least it's good to see it, in print. So the point is that there are well-validated, known, scientifically described pathways that tell us about what is shaping vascular health, the ability of the blood, genetic markers that make it more likely for an individual or increase their risk of cardiovascular disease because they have less protection of their blood vessels. So, so this is what starts to fit. And when we try, the particular thing that you mentioned, kind of saturated fat avoidance with your response to it, this area is a very interesting area. It's called nutrigenomics, right? Where we can give a patient an opportunity to understand how to fine tune their diet, at least on the macronutrient level, so that they could mitigate some of those genetic predispositions, right? And so that goes way beyond just like, eat low salt, eat low fat.
It's exhausting, but it also explains, right? I think that because, you have the diet wars, right? You've got the vegan camp versus the carnivore camp versus any other camp. And I think that the Mediterranean camp wins more battles because it allows for more normalcy. But we would be foolish to discount the fact that there are people who thrive on a carnivore diet.
Exactly.
The problem I have with the carnivore people is when they run around talking about how everybody needs to be on a carnivore diet because it works so well for them that surely the whole world would be saved. And same with the vegans. And you finally a voice of reason that's saying, just stop. Like, yes, maybe there is a subset of the population that will thrive on a carnivore or a vegan or a whatever
or even ketogenic diet,
or ketogenic diet.
So there are all these, like, you open YouTube and and you see like a bunch of people and say my LDL is 500, and I'm like, and they're well-known people. They have tremendous amount of following. They're MDs, they're PhDs, and I always think to myself, okay, your LDL is 500 now. You're in your 30s. Let's speak in 20 years. So so this is so there's so much I think misrepresentation and kind of this sensationalizing approach that the whole message is sort of lost in translation. And the message that needs to be is that vascular disease, vascular aging are not linear phenomena. We know that from old studies. We know that 50% of patients who present with their first heart attack have normal lipid profiles. This is not new data. We have known this data for decades. We also know that when we lower lipids, there is so-called 30% relative risk reduction. Well, 30% still leaves 70% untouched. And cardiology has a very cute name for that 70%. They call it residual risk. And, and I'm thinking to myself, well, any sixth grader probably knows that in math, residual is what remains of the whole. It's not 2/3 of the whole. So, it's that residual risk, which I think is now really become the forefront of investigations, both clinical investigations, translational investigations. And this is what patients want. And this is what, where the opportunity is. But it's not an opportunity that is cheap, and it's not an opportunity that is widely available. And that's where we're going to have, of course, a lot of friction in delivering this personalized intervention to whoever wishes to have it, because the insurance companies are still, and the traditional medicine, they are basically crisis management aligned business enterprise, right? They manage a crisis. And it's great because if you had a crisis, if I had a crisis, I want all of these resources to be available, right? But when you dedicate so many resources to crisis management, you don't really have much left.
Well, there's no prevention.
No prevention,
there's
right? None. So, the business model is not aligned to give people, an opportunity at prevention. What is the reason that insurance companies are refusing to pay for a medical grade genetic test that costs $500? What is the reason for it? And person is getting it once in their life, right? Why? Like there is no good explanation. So we've done close to 200 genetic tests, in our various individuals in our practice. And I can tell you that we don't have any discussions with patients with regard, let's say, to lipid and metabolism management without genetics, because there is no context. Genetics is the context that we need. So if you want that personalized management, you need to have the right tools, the right information to actually get that personalized management off the ground. Otherwise, you can do fire and forget. Have your doc give you NRX and off you go.
Yeah. Yeah. No. And it's anyway. All right. Let's go on to a different question. So how do you explain to patients the difference between treating a blocked artery and treating the underlying biology that made that artery vulnerable in the first place? I think, again, what you're talking about is in the conventional model, we wait for the blocked artery to happen, and then we deal with the fallout. With any luck, the person lives to tell the tale. The medicine you're practicing is assessing what are the vulnerabilities. So how do we explain this to people without freaking them out so that they understand that this is empowering, not frightening?
Well, it probably still will be frightening somewhat, but, in cardiology, even in traditional cardiology, we have transitioned from sort of forwards and backwards, because everything initially was very plaque based, right? Doing procedures, opening the areas which are blocked, which of course, if somebody is having acute myocardial infarction, is life-saving, right? So absolutely
has
to be done. Tremendous procedures. They saved countless lives, as I said before. And then slowly we transitioned from this sort of plaque-centric concept or what is known as a vulnerable plaque to a concept where we look at the patient in their entirety, called vulnerable patient, right? And so little did we know that in making this transition from vulnerable plaque to vulnerable patient, we have to go back to vulnerable plaque to understand full patient vulnerability, right? And that only happened because artificial intelligence tools gave us this window of opportunity from cardiac imaging, for example, cardiac CT, some of these new AI quantification methods that allow us to see plaque composition and measure its impact are now adding to our concept of patient vulnerability. So the way that I tell patients is this: if you have plaque in your arteries, consider it a done deal, right? Let's say there is some calcium buildup, right?
Okay.
Calcium buildup. That's a done deal. We might be able to shrink these plaques somewhat. There's something known as plaque regression, but the calcium is not magically, it's not going to, evaporate or clean out of your arteries. And so I'm sure your listeners are going to flood you with comments and said, this cardiologist said that there is nothing that's clearing out calcium, and I've been using this supplement that has done that. We'll have a separate discussion, but biologically, calcium cannot really leave the arteries. It's the process that is finished. So, imagine if you, let's say, scraped your skin and eventually there's a scar. The scar is not automatically going to disappear from your skin. Maybe you'll do some procedures like lasering and it will faint, but it will always be there. The molecular changes, cellular changes will always be there. So I try to shift their perspective from focusing so much on that coronary calcium or known areas where they receive stents, and to impart upon them that they have control now, if we figure out exactly what's going on with them, to prevent this from happening ever again. And that means that we have to unravel the root causes that are putting vessels into that inflamed situation in the first place. And that's more complicated, right? We already spoke about genetics, certainly metabolic, microbiome, hormonal influences. This all has to come into place to slow the process of vascular aging, because it's that vascular aging, the end result being inflammation, immune system reaction, that actually is giving people plaques, is giving people events, is giving them, unfortunately, procedures because they can't avoid, right? And it's, and I especially, I feel bad when patients say, but doc, why did this happen? For the past 5 years, and let's say this is a patient who is 55. For the past 5 years, I stopped, eating fat. I go to the gym. I don't eat any gluten. I don't drink, I don't smoke. Why did it happen? And, and it's heartbreaking to tell patients is that, vascular disease is not disease over a 5-year time horizon. It's a disease that starts at birth. We know this. We know this, right? So unless you were doing all of those things when you were 18 and you continue to do them, sort of repeatedly, of course, there is an impact, but it's not the level of impact that people expect. And I think that's where the major, emotional sort of problem is that, people feel crushed. They say, why am I doing all of this? Why have I been doing all of this? They feel that there's no validation to their efforts, and that's because I try to give them a sense that they can be in control. They can absolutely reverse it. But that linear, I've done everything right for 5 years. Why am I having blockages? That's just not biology.
It doesn't compute.
Does not compute.
There's a narrative that there are major aging inflection points at the age of 40 and the age of 60.
Mm-hmm.
You might say that the age of college is another major inflection point because if you think about it, some of the greatest assaults on our physiology first happen in those years where you're sleep deprived, you're drinking, you're not eating well, you're stressed to the nines. It's the fun years, and we often say, they're young, they're resilient, they'll get over it.
Right.
But I think that the body, the impact on the physiology, nevertheless, is registered.
Right. For sure.
There's no forgiveness. And this isn't to freak everybody out, but it's just to say, now, if you do this while you're in college and then you come to your senses in your 20s and 30s, you can slow things down. You can probably reverse stuff. You will not, but unfortunately that can often start patterns that get carried through young adulthood. And then life takes on and you've got new stresses and all that stuff. And so it just builds up so that 5 years you were good, unfortunately wasn't enough to undo the 30 or 40 years that's true, where there was accumulation of effect.
And there is a concept, it's a concept in neuroscience, and I, looked a bit into that concept of hormesis or hormetic threshold, right? And that's what you're referring to is that, in simple human language, it's basically whatever doesn't break you makes you stronger. That's what hormesis is. So when we exercise, for example, we do, induce some wear and tear on our system, right? But why is exercise so beneficial? Because there are hormetic effects where it leads to improvements in cardiovascular, tolerance, in drops, vascular resistance, promotes some muscle growth, and has a lot of other benefits, reduces inflammation, improves insulin sensitivity. So, however, too much exercise, right, for specific individuals will have the opposite effect. So, so I think as we go in this line, this more individualized line, the possibility there is that each individual will have the tools. And I do believe that those tools, just as it happened with human genome, which initially was super expensive to sequence. And now you can, like I mentioned, you can get this medical grade genetics for like $500. And, if you want more, you can get it maybe like for certainly under like, 2000 for sure. But the point is that we will give each person an opportunity to understand where they are and what they may or may not want to be doing. So it is empowering. It is patient agency because it's giving each individual a choice, right? You can be like Brian Johnson, who made himself into a huge science project, and he feels, very empowered by it, reversing his biological age, or you could be, as my grandparents used to be, who actually had a healthy lifestyle, but, they would always do the same thing, not listening to any fads. And they lived into their late 90s, and they had a pretty hard life. So, so this is sort of, and all things in between.
100%. I feel like genetic testing should almost be offered as a pediatric foundational source of information, because if we knew as parents And I don't think most people are ready for this, to be fair. But to the parent that is particularly enlightened, how great would it be to have, because your genetics don't change, how great would it be to understand that this child will do exceptionally well with, I mean, we're talking about fat and carbs, let's say, with a higher fat, lower carb diet right from the beginning, versus this child who actually can do really well with higher fat, and like the opposite. Like, if we believe that aging starts from the day that we're born, then how soon is too soon, you think, to get those kinds of insights without being neurotic about it, but just taking it, because now lifestyle really can take a real role here in how we age. Do you think?
So it's a interesting question, and I have to tell you, from the ethical perspective, there's of course going to be challenges there,
issues,
right?
the
issues, because what if it's a situation where resources are very scarce, right? And you can't really get to these resources, an individual, just trying to survive. There was a study in cardiology, I believe it was called Pure. It was a very interesting study because it was specifically looking at the impact of meat consumption over multiple countries. The countries were spread over 7 continents. And so the premise of this study was that the expectation, the hypothesis was that the less meat people eat, the better cardiac outcomes we're going to get, right? Because the idea was that it was plant-based diet. So what they found was actually the opposite. And the reason why this was the opposite is because in some of the countries that participated in this study, the population's access to food was primarily focused on ultra-processed foods. And yes, there technically were not meat foods. And you could even say they were plant-based, right? Potato chips are plant-based. So, but the point is that they found that there was another variable that they didn't expect, that actually showed that less meat consumption led to worsening of cardiac outcomes, because people who did consume meat were most likely had better access to resources and they ate cleaner.
So they're better off.
They're better off. So I think, so this is where I think we are going to draw a lot of difficult issues that need to be resolved. And, another, as somebody who is a mom, reflecting, thinking about my children, when were my children receptive to the idea that they need to do certain things differently, right? It didn't really happen until they were sort of in high school, their late teens. And even then, there had to be some sort of a motivator, right? For sure. But at least there was some insight into that. So I think it would be, I think for sure, I'm hopeful that now that people have more access to direct to consumer genetics, not that if they have access to medical genetics, which is what we do, that's so much more valuable. But if that's not the case, and there is some direct to consumer genetics access, now with the AI tools, there is actually the beginning of the opportunity to personalize.
Yeah. I mean, I guess I was thinking more in an ideal world, kind of not realistic. You know what I mean? In an ideal world,
yes,
we might come into this world with an understanding of what will be best for us,
right?
And so that we could start acting on it sooner. But obviously, it's not realistic.
But I think as these tools become less expensive and more easily accessible, people will actually, I call them citizen doctors, right? So, so citizen doctors will redefine how we practice medicine.
For sure. So if someone says I'm into longevity, but they really haven't seriously evaluated their heart health, what do you wish you could tell them quite bluntly?
I ask one question of every patient, whether they're referred from longevity doctor or not. And I ask them, do you know your vascular age? And if the answer is no, then I know that they have not even scratched the surface of the most important factor. Because, longevity, let's face it, longevity in many ways is a business. It's a lucrative business. It's growing very rapidly. You can call yourself longevity anything at any time. I think I may actually know who the patient is whose wife told you that he is working with me, because I believe it's the same person who told me, Dr. Druz, you can call yourself anything you want in longevity. Just go for it. So that's what she told me. But
smart woman.
Exactly. So, but longevity is, one has to be very deliberate with regard to longevity. And the number one priority is vascular health. Why? Because vascular health not only telling us about the opportunity for optimization for vital organs such as heart and brain, but it's also a window of opportunity to understand the fundamental processes that drive aging, right?
Mm-hmm.
That inflammation, chronic low level of inflammation that people start to get in their middle years and sort of accelerates as they get older, it plays out first and foremost on the vascular surface. And so we know how to measure this. There are good techniques, whether it's scanning the carotid arteries or measuring, arterial stiffness, or even if calcium score could give us some idea where a person falls. So that's so fundamental that if you don't know it, everything else that you're doing is sort of superfluous. And another reason why it's so fundamental is that the ways to improve that, that vascular age, and we can measure vascular age, which is dynamic. For example, VO2 max, right? Mm-hmm. One of the most, if not the most impactful metric for aging is VO2 max. And it is cardiovascular. So, and again, there are plenty of tools, that you can measure it. Even Oura Ring right now, you can go run for 6 minutes or walk fast. It's going to give you your VO2 max. But the point is that the way to change these parameters are fundamentals: exercise, nutrition, stress, resiliency building, reducing sleep fragmentation and sleep disruption, eliminating toxins. And these are so fundamental that they are not only there to reverse vascular aging, but these are impactful for lowering the risk of neurodegenerative diseases like Alzheimer's. These are impactful for lowering the risk of cancer if a person has cancer, lowering their risk of recurrence. These are impactful for overall health trajectory. And so that's why if they tell me they don't know their vascular age, then it doesn't matter how expensive the peptides are. It's just not getting there.
I love it. So genetics and what you just mentioned, the metabolic health, the hormones, the inflammation, the toxicities, the stress and the sleep. What's more important, or are they on an equal footing? You basically need that genetic insight and that. Like, if we can put those two things together, how much trouble can we really stave off, do you think?
You know what? We probably could stave off anywhere from 70 to 80% of age-related deterioration, right? It doesn't mean necessarily that a person, and, clinical data and research data supports that. It doesn't mean that nobody is going to get, let's say heart disease, but people may get heart disease in its much milder forms where it's not impairing their activities or leading, let's say, or get fewer heart attacks and things of that nature. So genetic is that foundational layer that we need to have, because it gives us an understanding what are the most impactful areas where we need to go. But genetics is tricky, and it goes back to your earlier question. Should there be a genetic opportunity for children when they're young so that we can learn what's the best nutritional strategy for them to prevent them from developing diseases when they're adults? Well, genetics is the blueprint, but it's not the entire house of health, because people may have genetic variants. And despite those genetic variants, they don't have any evidence that those genetic variants are actually impacting their health at all. Right?
Yeah.
And that's actually more common than people who have diseases and then we find genetic variants. So genetics is complex. It's not, when people come and say, I had genetic testing, most of them don't understand that there is a tremendous difference between direct to consumer and medical grade genetic testing. They don't understand that, single evaluations of single genes are not the same as looking at multitude of genes, that's called allogenic genetic scores, are not the same as looking at the interaction of environment with your genes, which is where the opportunity really is, right? So until that complexity is simplified, I don't think we can have, an easy sort of rule of thumb.
Yeah. I mean, it's just part of the puzzle. So, okay, right. Let's move on to something else. Ectopic and epicardial fat. Fat stored around the heart and organs. So people are starting to get their heads around this, right? We speak to it very often as visceral fat, I think, certainly for the fat around the organs. So how do you explain what it is and why the heck it's so dangerous from a longevity perspective?
So great question. And, maybe like these are almost medical terms. So let's educate people on what those medical terms are. So ectopic sort of means elsewhere, and epicardial means on top of cardium and, your heart, right? Your cardium. And I talk a lot, with my patients and in my book about something called sick fat disease. And that's what I want, the listeners to remember, that sick fat disease is the inflammation of fat. And this is a newer concept, right? Because before we thought, people, they start to pile on that fat internally in between the organs, that's your visceral fat, in the organs, that's your fatty infiltration, for example, liver fatty infiltration. And of course, that damages the organs if there's too much of it because they just not functioning properly. But now we also know that the reason for that damage is that it creates these areas of inflammation locally. And that's how the damage happens. So there is an inflammatory, there's an inflammatory phenomena happening. And what we started to understand with regard to heart disease, for example, and heart disease is not just coronary artery disease. Heart disease could also be structural. Valve disease, for example. Heart disease could be electrical, like atrial fibrillation, right? A very common arrhythmia. So what we've begun to, and of course, heart disease, a big part of structural heart disease is heart failure, which is one of the most devastating types of heart disease, very much on the rise, especially in women. And that specific type of heart failure that's on the rise in women, so-called obesity phenotype heart failure, is very difficult to treat because the kind of mainstay medications for heart failure, the older medications, were for a different type, right? So what we learned from some of the recent literature is that there is fat infiltration of the heart muscle. There is fat that surrounds the coronary arteries. This fat is not inert. This fat actually is sick. And so sick fat disease, because this fat secretes a variety of inflammatory mediators that lead to critical inflammation, whether it's in coronary arteries or in the heart muscle itself. Inflammation leads to plaque progression, leads to fibrosis. And so we see these clinical phenomena emerge. And this is one of the reasons why I actually changed my opinion on, GLPs and GIPs, the medications that are basically making pharmaceutical manufacturers richer than ever, right?
So you call them GLPs and GIPs, just for the audience. These are GLPs and GIPs. These are the peptides of the decade at this point.
The peptides of the decade. And so, or the peptides of millennium. But, so I changed my opinion on these medications because the clinical trials have started to report that there are effects which are independent of weight loss. And these effects are due to anti-inflammatory properties of these medications, including their ability to turn off the inflammation in that ectopic or epicardial fat.
And does it reduce the ectopic and epicardial fat as well?
Some earlier studies using cardiac imaging techniques have started to show that. So the point is that, I sort of changed my mind on this because I said, well, this isn't just about weight loss, although weight loss is certainly, has part of it has its benefits. But, as cardiologists and a lot of longevity physicians will tell you that, weight loss in and of itself is not enough to reverse a lot of cardiac conditions or even cardiac risk factors, right? So it's just not a magic bullet that people think it is. Again, it's sort of the example of that linear thinking. If I lose weight, I'm going to be better. For some people, it works very well, and for other people, not so much, but what we find is that these medications appear to have other effects that are more powerful than weight loss, and that's silencing or turning off the visceral and inflammation, and inflammation which is vascular, inflammation which is in that fat tissue, that sick fat tissue. So that's the properties that are responsible for a lot of their effects.
That's unbelievable. I also think that fat loss, losing excess fat, and we're not talking necessarily the last 10 pounds, but if it can help to resolve sleep apnea, if it can help to resolve blood pressure, if it, the satellite benefits of those things, I think is what can pay off in huge dividends. But this lowering and reducing inflammation is going to be a massive piece of the puzzle. I want to get into women and menopause and those particularities. Okay. I think that one of the ideas that maybe you talk about is that menopause doesn't create new risk factors. It amplifies the ones that are already there, which I don't think is something that is commonly talked about. Mm-hmm. So what does that mean in practical terms for blood pressure, lipids, and fat distribution? Basically, I guess as women are coming into menopause, is there anything we should be aware of, or how is this all playing out from what you're seeing?
It's basically exactly what you said, right? So women that we know that menopause is going to change metabolism, it's going to change vascular reactivity, it's going to change sleep, it's going to change body distribution or body fat distribution to be exact. And of course, menopause, unfortunately, is the time of increased inflammation and stress on cardiovascular system. So if women come into that menopausal transition already with pre-existing cardiovascular risk factors, metabolic dysfunction, poorly controlled blood pressure, obesity, or high concentration of that visceral or sick fat, these will, of course, worsen with menopausal transition, not the other way around. Yeah. And, they believe that just sprinkling hormones on it will reverse it is not true.
No. So, okay, here's another one. Many women are told that their symptoms are atypical or it's anxiety driven. When you're listening to a midlife woman describing chest discomfort, palpitations, or exhaustion, what are the red flags that make you say, this is cardiac until proven otherwise, versus the current, which is, oh, that's just anxiety, and don't even look at a possibility that it's cardiac?
Simple answer here. She is reporting these symptoms. This is cardiac until proven otherwise. There is nothing else to do. Nothing else to do because we have great testing. It's not invasive. We can have an answer super quick. And even if it's not something sinister like a heart attack, and hopefully it's not, we could give an individual important things that they need to know about themselves to make sure that they don't have a heart attack.
Yeah, I love it. Where do you see hormone therapy, lifestyle medicine, and cardiology needing to talk to each other more intelligently if we're serious about protecting women's hearts and their longevity?
Another great question. So years ago, when I was speaking at the American College of Cardiology, I was in the little lounge area for the faculty, and one of the very well-known, esteemed women cardiologists, who was somebody that we all looked up to, told me that just asking about hormone therapy is malpractice. So I think that we've come a long way since then. I do think that there are pros and cons to the recent FDA removal of black box warning, because hopefully it will open the door to an informed discussion and personalized management, because appropriately started hormones, when additionally women's risk, metabolic risk, and inflammation risk is managed as well, could definitely make an impact, clinical impact. I think the downside might be that women will rush into hormone therapy without recognizing the fact that it is not a magical solution. And I see a lot of the women like this whose lipid markers, metabolic markers continue to be misaligned with the degree of hormonal therapy. So hormonal therapy needs to be individualized.
Yeah, it's like everything else, though. I mean, like you said, it's not a silver bullet, but it's part of the puzzle. So,
exactly.
So, I mean, I think I know the answer to this question, but should all women consider getting some kind of cardiac checkup at some point? And what age do you think? Like, when should we start to look at it? Do we wait for menopause? Do we do it ahead of menopause? Like, what do you think? And yeah.
I think the answer is yes. I think the same paradigm that we use for breast cancer screening with examinations that start in a certain time frame and continue annually will be something that we will need if we want to get ahead of cardiovascular disease in women. The question of when is an interesting question because I answer a lot of these questions based on genetic and laboratory markers, right? You could have a 25-year-old whose genetic and laboratory markers are very worrisome, or a 55-year-old where they're not, and you're more worried about sort of age-related progression of cardiovascular disease. So this is something that we will find out. But as a rule of thumb, I would absolutely say that any woman who is considering having children or had children, especially young children, needs to know her cardiovascular risk because she wants to be there for her children and for her family. Yeah. And that's the time when it's going to be most challenging for her to actually mitigate the factors that down the line will accelerate that vascular aging.
Yeah. Yeah. Well, I think we all aged through early childhood years.
Yeah.
Lack of sleep, stress, not taking care of ourselves. Right. Hopefully we mitigate it down the road. But yeah, I mean, I think the concept of getting a baseline earlier in the game, like maybe you don't need to be checked as often, but to have a baseline of what your normal is. And then if anything comes up, start to increase the number of times you look at these things would make sense. Okay, let's move into another one of your pet lovely areas, which is AI, wearables, and the future of precision cardiology. So you are not just a clinician. Part of your zone of genius is that you're a digital health entrepreneur. So when you look at AI and wearables, what excites you the most for heart-based longevity, and what really worries you?
Interesting. So I think what's exciting to me is that for the first time, we can actually measure a lot of things that people know they need to be doing, but they're not doing, right? And so let's talk, for example, about stress and sleep. We have great wearable devices right now, multiple executions that can actually provide good measurements and give us a window of opportunity to intervene. And some of these devices have actually gone additional step, and they're able to give us metabolic age and vascular age. And this is sort of the area that I would love to see more investigations and linking that to the outcomes, because these are great markers and great opportunities, but it worries me that we don't know exactly how to fit it in. Most of our data is a bit old, and, companies are coming out there providing all these metrics, but, the validation sometimes is just not really there.
Yeah. I mean, people get very excited about this stuff, right?
Because it's a number, right? You can relate to a number.
Yeah.
But, so the approach that we've taken is that we follow our patients, obviously longitudinally over time. And so we're looking for degrees of change as opposed to just the number itself, because the number itself may not be robustly validated.
In your own podcast, you've talked about pocket-sized ECG devices and AI analysis that could change how we monitor rhythm issues. Like,
Yeah.
do you have a story of a patient where something got
So,
picked up out of a
so this
pocket?
is, I have to say that, Dr. David Albert, he's a great friend and the, cardiologist entrepreneur. And that was one of the, I truly loved having him on my show. But, I was an early adopter of this device and I made it available to all my family members. And we were driving, from a long distance trip. My children were still young and my son started feeling unwell. And, we had to make a decision. Should we stop and, let him out? Or, he was sort of feeling dizzy. Or should we continue? We're in very thick traffic, not a very good road situation. Actually, we're on the bridge. And so I whipped out my little device and I said, okay, let's take a reading. And, and I could see that, there were no unusual signs. His heart rate, his heart rhythm were entirely normal. And so, it was probably just a reaction to sort of, being on the bridge, being in the car, being a little hot, being dehydrated. So we were able to talk him out of it. And, and I thought to myself, well, that's really something because, otherwise I may have just, taken him to the emergency room, right? Because you don't know, but information is power. And, and I think Dr. Albert with his 1 million plus ECGs has, I know there are cardiologists who use this mid-flight, to diagnose myocardial infarctions. There's just so many uses, but, it is yet another great opportunity to smartly use available tech, for health and disease.
So this is a device that's actually available?
Yeah, one can go online and buy it. Now they made it the size of a credit card. And so you can go ahead and it's called Cardia, so you can basically carry it as if it were a credit card in your wallet and, get it out and, and just put your fingers on it and gives you your ECG tracing. So,
That's
they
amazing.
actually now did a device which is a full electrocardiogram, but that's not for patient use. That's for professional use.
Right. Well, I have something sitting upstairs called Connect Q. Have you heard of this?
Use Connect Q. That's your arterial stiffness measurement device. That's
I know. Well,
that's part of that vascular age estimate, right?
Well, we'll have to check it out because it's been hard getting me on the app because I'm in Canada where it's not approved, but they finally figured out a workaround. So you and I can have a conversation about that another day.
We have to talk about arterial aging. Yes,
for sure.
Specifically.
Okay, stress trauma and the heart-brain longevity axis. Do you want to talk about that at all?
Yes. Yeah. So we had, several discussions on my podcast on that. So, it's interesting because your heart, or your blood vessels rather, and your heart, is part of a echo-phenomena loop, and that loop was described by investigators at Harvard Medical School. Dr. Peter Libby and his group done a lot of investigations into that. And what they linked the activation of stress response in the brain, right, amygdala activation, to recruitment of the inflammatory immune system cells into the vasculature and ensuing immune and inflammatory response, right? So there is a biochemical and physical connection. And, they describe this phenomena in patients who had a heart attack because, first of all, heart attack is painful. And second of all, emotionally, it's very distressful. And, I learned from this early on because when I was in the cardiology fellowship training, one of our fellows was from overseas. He was trained in Europe, actually in Ireland. And so he was part of our group of fellows. And when we were admitting patients with heart attacks, he would always tell us, how come you're not prescribing morphine? And we said, why should we be prescribing morphine? What's the cardiovascular indication? And he said, because you want those patients to feel less pain. You want them to be a little bit more relaxed in their brain. So because, you need to manage that whole emotional surge. And, I thought it was whatever. And then, research came out and said, the kind of other country techniques may actually be applicable here. So huge connection. And I think there are a lot of interesting wearable devices in that regard, right? So we're talking about vagus nerve stimulators, of course. There's a very interesting one that stimulates auricular branch of vagus nerve.
Yeah.
Right? So,
is that
Yeah, exactly. And so that could be something that people can actually use consistently to, turn the stress dial down.
So speaking really to the heart-brain connection and stress and trauma, we'll do another podcast episode just on that, because I feel
this one is its own
topic,
discussion.
But it's interesting that it is still not fully accepted in conventional cardiology circles. I think that I actually spoke to a cardiac surgeon who's devised an artificial heart, and it's brilliant. And I'll be doing a podcast about it.
Mm-hmm.
You and I can talk about it offline. But when I asked him, but what about losing that emotional center? He poo-pooed me. He blew me off completely.
No. It's there. And of course, we practice a lot with our patients. We use heart math, which is heart coherence technique, in addition to vagus nerve stimulators. And we know, for example, that the connection between what the brain is feeling or thinking and your heart is very close. We know from the literature that people who experienced adverse events in childhood, so-called adverse childhood experiences, or ACE, have a much higher incidence as adults of hypertension, heart disease, metabolic disturbances, right? So there is an echo phenomenon that, these investigators described that I think goes beyond just, here's the coronary plaque and, your brain recruits immune cells to go there and clean it up. That's the biological, pathway. But I think we have wiring that is meant to connect our brain and our heart on levels that we cannot fully understand, but we can modify, at least to a degree. And, for example, why is loneliness is not a recognized cardiovascular risk factor? There's been a lot of literature on that, and it should be.
Yeah, 100%. 100%. Yeah. Okay. For someone in their mid-40s or mid-50s who's worried that they may have missed the boat, what are the first 3 numbers you want them to understand about their heart health?
Ooh, good one. So I would start with blood pressure.
Yeah.
Because it continues to be still the number one most impactful risk factor for heart disease. I would start, additionally, I would have them check their ApoB, which is, let's think of it as a sum total of all atherogenic cholesterols that could cause atherosclerosis. And if they don't have access to ApoB, they can just stick with LDL-C or non-HDL cholesterol as surrogates. Not the best surrogates, but that may do, if they could quickly calculate non-HDL cholesterol from a standard panel.
And where should it be? Where do you like to see it?
Anything less than 100 is good.
Okay.
So if that's where they are, because if they truly have an optimal profile, they will have, LDL cholesterol somewhere around 70, and non-HDL cholesterol is usually 30 points higher. So it's around 100, and their ApoB will be somewhere 80 or less. And that would be pretty close, very good optimal profile. And I would ask them to know their lipoprotein a, because, this is definitely emerged as a very powerful risk factor. Has a little bit of a different biology, possibly in women versus men. So, has a very heavy genetic predisposition. So there is a lot to be said about its impact on vascular health.
Love it. Okay. And what does a simply weekly routine for heart-driven longevity look like for a busy adult? Movement, nutrition, recovery, and connection, which we just talked about.
That's right. We talked about. So I would say that prioritize sleep, because sleep is an opportunity for recovery at multiple levels. Build stress resiliency, which means, build techniques or opportunities not to be somebody who reacts to stress, sort of manage it proactively, avoid situations which are likely to compound your stress, whether it's time constrained or some other situations such as like that. Do embrace time restricted eating. It's a great strategy, underutilized by a lot of people for whichever reason. People don't necessarily understand the difference between intermittent fasting and time restricted eating, but there is a difference. And make meaningful relationships count. because, and your family, your friends, those relationships are the lifeline. They are what your heart needs and what your brain needs in order to be healthy. They give you purpose. And so that's, those would be my quick tips to the
Love
busy
that.
people.
So just quickly, because people will be scratching their heads, very quickly, what's the difference between intermittent fasting and time-restricted eating in your mind?
Right. So intermittent fasting is essentially refers to a period where a person doesn't eat, but it could be any period. For example, typically we don't eat at night because we're asleep. So each of us practices intermittent fasting to a degree when we're asleep. Time restricted eating attempts to restrict the eating window around or in more alignment with your circadian rhythm, which basically means that people would eat, let's say from 10 a.m. to 7 p.m. during the daytime hours. They essentially restrict themselves to eating, a little bit after the sun comes up, and they stop when the sun goes down. So, that's the time restricted eating period.
Perfect answer. Thank you. All right, quick fire. Okay, no, like one more. What are the seemingly normal symptoms or test results that would make you say to a listen, don't ignore this, it's your heart asking for help?
Seemingly normal.
Yeah, the symptoms or test results.
So symptoms, I would say, because the cardiac disease could be devastating, and because there are people who unfortunately drop dead without, as a friend that you mentioned, who don't have seemingly any red flags. Heart disease tends to be silent. Anytime somebody has a symptom, whether it's chest pain, palpitations, shortness of breath, they shouldn't really ignore it. If it was something that was a one-off and there's a good explanation, perhaps. But if it comes back, it's meant to be evaluated. And we have really robust evaluations, and there is no need to guess because we can know the answer.
Well, and once you've knocked it out, you've knocked it out. All right. Our last 4 quick fire questions. So these are quick.
Okay.
One lab marker you'd never want to lose access to.
High sensitivity C-reactive protein.
Inflammation. Got it. One wearable or device you actually trust for heart and longevity.
My Oura ring.
Beautiful. One daily habit you think is underrated for protecting the heart.
Gratitude.
Love it. One question you wish every patient would ask their cardiologist.
Doc, is it going to work for me?
Oh my God. All right. When you think of extending health span rather than lifespan, what does a long, good life look through a cardiologist's eyes?
It's a life where you can still walk, talk, and do things that you want without limitations.
Love it. Dr. Regina Druz, this has been an epic interview. Thank you for this conversation. You have a book coming out.
Yes.
So I would love to invite you to let people know where they can follow you, where they can learn more about the Holistic Heart Center, and find your book when it's available, or maybe pre-order it by the time this podcast comes out.
That's right. So thank you so much, Natalie. So Holistic Heart Centers is super easy. It's holisticheartcenters.com. And you will see all of our programs and all of the things that we do. And there is even a page on there that refers to Holistic Heart University, where if you want to learn more about this type of information that I speak about, you could go ahead and, sign up and learn more. And the book is coming out sort of late 2026. It will be called, the tentative title is Longevity Code. And you can find more information at drreginadruz.com. So just type it all in.
Thank you so much, Dr. Druz. This has been fantastic. Thank you
for having me.